everybody, and welcome to our virtual University of Best Practices. Please note that as you join, all attendees are muted, and this meeting is being recorded. We will start our meeting promptly at 12 p.m. and please remember to use the Q&A function to ask any questions, and use the chat function to notify the team of any issues that you may be facing with your technology or anything like that. Again, thank you for joining.
Megan, could you jump down to the next part of the agenda for a moment and then back up again? Oh, good. We have good critical mass coming together. I believe I saw Keith Emmons out in the participants. If you could please promote him to a panelist. So I want to thank all of our leaders from coming together from around the state. I believe we have leaders from the north to the south of California, including Los Angeles, the capital region of Sacramento, Santa Barbara, San Diego, El Dorado County, Lake Tahoe, we even have people joining us today from as far away as Ohio. So I want to welcome everyone, and I just want to thank our sponsors, the California Department of Public Health, in particular, Blue Shield. The University of Southern California has been a great supporter, as well as Los Angeles County Department of Public Health. We also have support from Amarin, Boehringer Ingelheim, Genentech, Johnson & Johnson, Amgen, Novartis, Novo Nordisk, and I particularly want to express my incredible gratitude to the National Institutes of Health that provided us with our very first grant that started our University of Best Practices. And in that grant, we showed a very significant decline in acute myocardial infarctions associated with our work, 86 million saved on their investment of 2.9 million and 3,826 fewer acute myocardial infarctions than anticipated over the first few years of our work there. So this is an extension of that National Institutes of Health grant, and I just so appreciate our leaders that have come together now in 4 regions. First San Diego, then Sacramento, then we had Los Angeles come on, and also our newest chapter is the Bay Area. So with that, I'll just say that we have an incredible team on board with us today, and I will pass the baton to you, Carol Zaher, to say a few opening remarks from Los Angeles.
Thank you, Hattie. I really, as you mentioned about the history of the RightCare initiative, it goes back a few years, and we've really made some progress, and I think we certainly have more progress to make with respect to, sorry about that, with respect to, let me turn that off, hold on. Sorry about that. In this virtual world, we are doing multiple things at the same time. I think the virtual RightCare initiative is really exciting because it does spread our message out further to many groups at the same time. Even though we have regional chapters, the ability to share the specific content of the different chapters is really remarkable, and I think very, very informative and helpful in this day and age when we not only have our mission to solve cardiovascular disease and improve outcomes in diabetics, stroke outcomes, and heart disease. But now we have the intruder of the COVID arena. I will say that the topics today I think are very exciting. When I opened my Wall Street Journal today, which is my new medical journal, it seems, the front page has two titles of articles: California, Arizona, and other states see rise in COVID-19. And right below that is the virus stalks families in large households, which is a very interesting article about not only population density in cities that seems to be important for the virus transmission, but also multi-generational family density in housing. And the editorial page today has the coronavirus good news, and it's nice to have some good news. I will just read the excerpt from it, which I think is very apropos to today's topics. It says, "Science and medical trial and error are saving more patients." So we are on the fly with this new condition and trying to understand it and solve it at the same time. And it's a challenging entity. So with that, Hattie, do you have any comments that you want to get? You are a stalwart champion for this whole initiative. Do you want to reinforce our mission so that we're all aligned with what that is?
I just want to say that our mission is really coming together, bringing the best minds together from everywhere to help drive down heart attacks, strokes, diabetic complications, heart failure. These are conditions that can be largely prevented. And we have, as a group, pulled together as a group of, I would have to say, amazing do-gooders from around the world, really. Even John Overtveit from the Karolinska Institute in Sweden continues to help us, even though his hours are not such that he can help during these Zoom sessions right now. He's very, very engaged in the fight in the operations team in Sweden, where they have a big problem because of how they have decided to manage the disease compared to their neighbors. So what we're trying to do, whatever the condition is that we're focused on, and really the original goal of the Right Care Initiative was to eventually cover all diseases, but heart attack, stroke, diabetes, and heart failure are such huge challenges. And it has given us 12 years of devotion where we're driving down rates of preventable events. So I will just flag for you that this triangle you see on your screen represents a quick synthesis of the things that we know are very, very effective. And I'd like to just let you know that on our webpage, many of these items, if you click on the links in that diagram, will link you to an in-depth project brief. So the writing is too tiny to talk about all of our amazing leaders from around the state, but it's online. I don't want to take the time to talk further about the overview of the project because we have a fantastic agenda today, which will be led off by Dr. Bill Baumer, super cardiologist from UC Davis. And could you please go to Bill's bio? So most of the people involved in the Right Care Initiative for the last 12 years know the wonderful Dr. Bill Baumer from our statewide summits and from presenting to our group with such amazing substance in this just-in-time learning group to spread best practices. So without further ado, I will hand the baton to the wonderful Dr. William J. Baumer, who brings his training in physics, medicine, and cardiology to us in a beautiful way to lead this, this group in such important work. So with that, Bill.
Thank you very much. And Brian or Jenny, if we could throw the slides up there, and then I will get to the presentation. So we're going to lead off today with a little bit about COVID-19. And as you can see, for COVID-19, it is the most lethal pandemic we've had in the US or around the world in the last 102 years. Next slide. So we do know quite a bit about this virus. That is the structure of it. Within about 2 weeks of us seeing the virus, we were able to, in fact, break it down and sequence it related to its exact RNA, as well as its structure, the spikes, the envelope, and everything else. So even though we're still learning about COVID-2, we do have quite a bit of information available for it, including when we translated or sequenced the RNA, we're able to, in fact, identify at least 156 mutations in the genome at this point in time. And next slide. Those genomes allowed us to trace where the virus had been and where it was going. So we were able to identify whether it came from the cruise ship, whether it came from different areas of Washington State, China, Europe, New York City, etc. And because each of these 156 mutations does allow us to identify in that particular virus where it came from. We do know that these mutations, once the virus is in your body, in about 2 or 3 days, that virus in your body will develop a mutation. And if it is a successful mutation, it may be, in fact, transmitted to others and become a more dominant strain as we talk about it. So lots of information is available because we can very quickly sequence this virus. That is the actual mRNA in the virus. Next slide. So we do know that this virus that we first saw as the first case community acquired in the US, we were able to identify the actual anatomy and confirm that the spikes on it are a pertinent part of the coronavirus, both in the description as well as its attachment. We do know that in identifying it, that we do quite a bit to help this virus. This virus by itself, as you can see in the photo, is not able to fly or swim by itself. It requires to get within less than a micron distance to our cells to get into them. Not only that, we are enhancers of this virus because we actually, our cells, through the TMPRSS activation, have to cleave the spike to allow it to effectively attach to that ACE receptor on our cells. So not only do we bring this virus in contact with our own cells, we actually facilitate the activation by cleaving the virus so that it can more successfully attach to a receptor on our cells, and our own receptor brings that virus into the cell, into our own cells to begin replicating at that time. So we do quite a bit to facilitate bringing this cell into our bodies. Next slide. And this shows that even though we do all of that, this virus is extremely sensitive because it can't do much by itself. And this data shows that this virus is very susceptible to the environment. Heat destroys it, UV radiation, sunlight destroys it, and any surfactant or detergent like soap or alcohol will in fact neutralize this. So this is a very, very sensitive virus, easy to destroy and doesn't get far by itself. And you could say, how in the world does this get around the world when it's such a relatively weak virus or cell structure? Next slide. Well, we can see that despite being relatively fragile as a virus, it has done well throughout the world. And since its introduction in November or December in China, it has certainly spread across the world. If you look at the slide here comparing various viruses, their infection rate and their lethality, you can see that the COVID-2 or the COVID-19 is in the pink box there, and it shows the relative infection rate and lethality of this. And if you look on the comparison with other pandemics that we've had, this SARS-CoV-2 or the COVID-19 virus is less deadly than SARS and smallpox and Ebola, other ones that have been around, more deadly, obviously, than the common flu or common cold. We note that it is a little bit more infectious, meaning thus, as we go to the right, it becomes more infectious than a little bit more than the common cold, which is often a coronavirus as well, and more infectious than seasonal flu, probably because many of our herd is now vaccinated for seasonal flu. It's similar to Spanish flu, the pandemic of 1918, and that's why I say this is the most significant pandemic since 1918, so 102 years ago for that. We do know the area of the pink is not a dot, it's a range. That is, the infection rate and lethality for SARS-CoV-2 varies across different populations and reports. Why is it that that varies? Next slide. Well, we can see that the infection rate for this will depend on what type of environment you're exposing individuals to. So I show this slide now. If you've want to practice in a choir, what is your risk? And this is a single choir practice of 2.5 hours in the state of Washington, attended by 61 individuals, where one case was known to have COVID going into the choir practice. And at the end of the choir practice, you can see that there's about 86% of the individuals are going to come down with COVID. Next slide. This shows the seating in the choir. The person in red to the left is the one who had COVID going into choir practice. And you can see the people in yellow are everyone from that single 2.5-hour practice who came down with COVID after that, and their seating arrangements. The ones in white at the bottom far right are the only people, 8 people, who walked out of that practice without COVID-19. So you can see how very infectious this was. Is this an R of 1? No, this is an R of literally 90 or 70 at that point for infection at that point. So we can see that it's significantly more infectious depending on the situation or the exposure that is offered to the virus. Next slide. This is another situation as in California and other states, we start to go into reopening, and people are saying, well, maybe we can go into a restaurant. There's going to be more distancing, and we're going to study a group of individuals who in fact were exposed to it in a restaurant in China. Next slide. And this slide shows a restaurant, the tables at the bottom shown there, and the circle in blue is a 6-foot diameter around the single case, A1 in orange, that had COVID going into the restaurant. So you can see that we would expect that there might be 2 people within that 6-foot radius who would be exposed to COVID, who might come down with it. So we might have from that single case 2 additional cases for it. But what we can see is the red circles are those who actually came down with COVID. And there's 1, 2, 3, 4, 5, 6, 7, 8, 9 individuals from that one that came down with infections from COVID. And notice that they weren't all sitting at the same table. It infected people in the table behind, the table forward, that were much farther than 6 feet away at that time. There was air conditioning blowing, in fact, to the left of this slide. And even individuals who were upstream of the air conditioning came down with COVID at this time. So we can see that in a restaurant, the entire half of the room came down with COVID at that time, and it was farther away than the 6 feet separation. Next slide. So COVID, once you get it, can create a plethora of symptoms. Loss of smell is one early one, but you can see that on the left, it affects every system with symptoms. And so you may present with GI, pulmonary, or just bad feelings or in your initial presentation. On the right, SARS-CoV-2 does affect, as far as we can tell, almost every organ system in the body. And today we're not going to discuss every one of those, but we're going to focus a little bit on heart and lungs. Next slide. So in the lungs, which is often the most significant infection that we see, and an early one, because SARS-CoV-2 gets into the respiratory cells. Most of those cells do have an ACE2 receptor, so it's easy for them to get into it. And they're spread often by aerosol or droplet contamination, so you inhale it into your mucosal surfaces or your lungs. Early on the left side of the stage, is the early stages of COVID, where the virus is getting into the respiratory cells, and the respiratory cells are manufacturing more virus or replicating more virus that then gets released. And that's the early stage of it. The second or more severe stage is seen to the right, and that involves both viral inflammation, viral infection, and often a immunologic response. Now that immune response, if effective and appropriate, can terminate the illness. On the other hand, you can sometimes have an overactive immune response leading to cytokine storm. These cytokines release inflammation throughout the body, which can by itself directly affect many of the cells of the body, leading to actual damage and destruction of cells in the severe stages, leading to this hyaline membrane thickening ground glass appearance in the lungs, which can precipitate acute respiratory distress in these individuals. Next slide. This slide shows on the topic didn't come out right, but COVID, acute respiratory distress syndrome. And what we see for that is an immediate hypoxic respiratory failure. And we document this by PaO2 to FiO2 ratio less than 300. And that means we're giving 100% oxygen, and you're seeing less oxygen getting through into the lungs at this time. So how do we treat that? It's vital that we think about how to treat this. We do know today supportive care is low tidal volumes. If you overinflate the lungs, you further damage them at this time. So we want to keep under 6 milliliters per kilogram of ideal body weight. We want to be careful about PEEP, expiratory pressure, because in addition to volume trauma, there is trauma from electasis, and by opening and closing the alveolar units, you actually induce more damage at that time. So you want to reduce the opening and closing events in the lungs, reduce volume, which would stretch the lung and further damage them. And we tried to minimize the driving pressure, the difference between plateau and PEEP in those. And that's critically important and has been vital in reducing the mortality that we see in these individuals initially reported at something like 3%. We've been able to get it down to approximately 1% by using this type of careful pulmonary therapy. Next slide. And of course, the 3 Ps are important when treating a COVID patient: prone, paralyze, and prune. Prune means we don't overhydrate them. Paralyze means we actually prevent them from fighting the ventilator. And by doing that, we can reduce some of the damage in the lungs. Prone means we're trying to improve the match between perfusion and ventilation in the lungs. And in a COVID patient, that often means flipping them onto their stomach. And obviously, the prone position at that time helps get them ventilated at that time. Unfortunately, refractory hypoxia can still occur in these individuals, and we have to have the ability to go on ECMO or extracorporeal membrane oxygenation. When their lungs fail, we have to provide oxygenation through a different way. If you have severe pulmonary problems, you can get RV dysfunction. The right ventricle, because of pulmonary hypertension, has a hard time pumping blood, and the ventricle or the heart starts to fail because of the lungs. Next slide. And what we can see in this is there are a variety of not just lung disease, but comorbidities associated with it. We've talked before about hypertension, obesity, and diabetes being areas that increase the risk of not only developing COVID-19 hospitalization, requiring ventilation, and actually leading to death. So higher incidence in those individuals. This disease is clearly more severe than flu, kills more individuals at this time, possibly because no one is immune to this disease when it started out. The prognosis for this disease can be severe in ARDS with a survival rate of 25%, meaning 75% are dead at that time. It is especially effective in individuals who are older, people over 65 years of age. And hopefully I'll show you at a later time that if you're 65 years of age in the setting of COVID, you're the equivalent of 80 years of age. So it literally adds 15 years to reduction in your survival at that time. We know that cardiovascular involvement is common with COVID, with myocardial injury, ischemia, heart failure, and cardiac arrhythmias being seen in all of those individuals. Next slide. So where does that lead us? Age is certainly a significant risk factor. Our immune capability declines as we get older, so we're at higher risk for it. We also seem to be a little higher risk for a pro-inflammatory reaction, the cytokine storm that can occur. So elderly or older individuals does increase the risk. We want to avoid those individuals getting exposed to it. Next slide. And this confirms what we had before: hypertension, obesity, chronic lung disease, diabetes, cardiovascular disease, all increase the risk. And for almost all of these, as you get older, the risk goes up for that, creating more likely intubation and literally death from the disease. Next slide. So we do know that one of the markers in the heart, troponin, which is released in the heart, is one of our best predictors of death. If you have a very high troponin, your mortality rate is 70 or 80%. So the heart is involved in this process of multi-organ system disease. Next slide. And so it is complicated because we also look at troponin for patients with acute coronary syndrome. We have to have a chart or a pathway for going through to try to separate acute coronary syndrome from actually the troponin muscle enzyme elevation seen in COVID patients. And so we can go through a process or algorithm shown here to try to separate out those individuals. Next slide. And why is COVID-19 create heart injury? A variety of reasons. It certainly interferes with the ACE2 mechanism. ACE2 is part of the renin-angiotensin system that regulates our blood pressure and our cardiac health. Hypoxia creates further problems of acidosis, in fact, jeopardizing the heart at that point. Microvascular damage is seen of the vessels, the very small vessels, and those very small vessels can actually get blood clots in them as well, creating further damage. Systemic inflammatory syndrome now leads to cytokine storm, which in fact involves all of the body systems and organs at that point in time, leading to further injury in all areas. Next slide. So what makes an individual high risk? We said before, I think that high levels of troponin of the heart are a very high predictor, 70% mortality in those individuals. Individuals with this should be carefully monitored, supportive care. We want to continue everything we can for our cardiovascular patients and our pulmonary patients. Next slide. Vascular events, including coagulation, occur in these individuals. There's some evidence that anticoagulation, antiplatelet therapy would be recommended in these individuals. We clearly want to continue statins, and we do want to continue ACE inhibitors and AR blockers because there is data showing they continue to be protective in these individuals. Some of our therapies have electrical disturbances, and there is a prolongation of QTC with this disease. So we have to worry about cardiac arrhythmias as well in these individuals. Next slide. And this just shows the process of SARS coming into CoV-1 and 2 coming into the cell. And it starts on the top with the initial interaction, the cleavage of the spike to allow it to come in. The virus enters. It then goes through several processes enhanced by our own cells. And our cells actually replicate the virus. We make the virus, manufacture it, package it in our Golgi apparatus, and then release it out. So there are 7 steps shown to the right that are required for this virus to get into our cells and then replicate and then be released. The advantage is each of those 7 steps has the possibility that we can interrupt them with current medicines that we have today available for us. So we've got 7 ways to attack this virus right now. Next slide. And this just shows that those processes to attack the virus are being evaluated. This shows almost 2,000 studies ongoing today to interact or to interrupt this virus at this point, currently registered on clinicaltrials.gov. 2,000 trials ongoing today. Next slide. So what have those trials shown? We have come up with a couple of ways to treat it. The first that we've used, remdesivir in the top, blocks viral replication in the cells. So it disrupts the reproduction of this virus in our cells. There are several other drugs that have been used to block replication as well that can be seen currently in trials. These are some of the promising trials that have shown benefit and reduction in events at this point to block the viral replication. Next slide. We can also try to prevent entry of the virus into the cells. We can do it by releasing decoys that attract the virus so it attaches to those and not our cells, the so-called decoy approach. We can also develop neutralizing antibodies. They can be manufactured ahead of time and injected in individuals to prevent the virus from actually getting in and attacking it before it gets into our cells. And lastly, for the hyperimmune response, we do have antibodies that specifically block IL-6 and an aggressive immune system to tamper down our immune overactive response. Next slide. And so the ultimate is obviously going to be, can we get our herd immune to this through a vaccine? And so very early on with the first patient we received, we immediately took their RNA, we generated a vaccine from that, and we used that. Now, part of the vaccination is to realize the interaction between the virus, the initial cell, respiratory cell, it interacts with the respiratory cell interacting with the dendritic cell, which then interacts with the regional lymph node to give us the beginning of the antibodies that are needed for that. On the right, it shows that it takes us anywhere from 5 days to 2 weeks to generate immunoglobulins, IgG, that we can use to defend against this virus. So how do we replicate that without having to undergo a full viral infection? Next slide. And this just shows the development of a virus vaccine. The idea is we want you to get antibodies, but not have to endure the entire virus infection. So in the early days on the left, you can see for polio and other things, we had a weakened or killed virus we injected or parts of it. Today, genetic engineering allows us to be much more efficient, not wait months or years to develop the vaccine, but initially inject the genetically engineered part of the RNA into different things like plasmids, lipid cells, or adenovirus that can be used then to inject into individuals to develop the antibodies. Next slide. And this shows on the top the injected solution. We've used that to initially test our vaccine in cell cultures. And if it was effective, we then moved on to animals. And we then quickly went into primates in our center. And we have now shown that these vaccines work in primates to prevent reinfection of this virus in primates very close to humans at this time. So we've moved on to human testing. And there are several vaccines that are currently out there and entering human testing at this time. So when we started out, next slide, we said that we're probably 6 months to 18 months from it. And I can tell you we're pretty close at this time. We're another 6 months, which will mean we'll probably have a virus right about 9 months after we first discovered this, which is pretty rapid at this time and right in the middle of our 6 to 18 month prediction initially. So what do we do right now is we reopen at this point in time. We can only do it safely by continuing our standard of care, which we went over earlier, is this very intensive respiratory support in individuals with additional medicines available to try to restrain the virus and reduce it at this time. But ultimately, we're going to progress to vaccination at the lower right as the only way that we can effectively protect much of our population at this time. Next slide. And so part of that interim period means we'll have to do more testing, and the testing requires both culturing for the virus, detecting it with PCR, as well as detecting individuals who may be protected because they already have antibodies. Next slide. And that's why today we're moving on from this to another area, and that is telehealth. One of the reasons in this interim period we'll have to do is keep separation from our patients and our healthcare providers. To do that effectively, telehealth is the most effective way of doing it. This shows adult and pediatric telehealth services at UC Davis already developed. And that's a pretty developed area where we have over 150 publications already on telehealth, and it fits nicely with COVID-19. And And that's why we'll be discussing it today in two of our subsequent presentations. Next slide. So telehealth, as we started out, is on the upper left, was a communication between a physician and a patient. It migrated to teaching, shown on the upper right, processes. On the left, you can see team approach is directly applicable to telehealth, where an entire team in an intensive care can communicate with a remote intensive care unit to provide the best possible team approach to those individuals. And lastly, on the lower right, you can see that telehealth also has the possibility of helping the patient directly. Here is a COVID-19 patient intubated in bed who is communicating with their family who otherwise cannot come in and see the patient. Very helpful for the psychology of the patient who's intubated to know there is still an outside family world that cares for them at that time. Very important for their mental health at that time. Next slide. And with that, we'll move on to our next speaker is Matt Monocot, who is at the other end of the lake. And Matt is the medical director for Barton Community Health. And I do know that Barton has had patients with COVID-19. And so in an area like South Lake Tahoe at Barton, Matt is going to give us the scoop on how they approach COVID-19 and how they've been able to handle it. So thank you, Matt, for joining us today.
Yeah, thank you, Bill. It's been great to be part of the University Best Practices for about 8 years for myself. And it really changed in the last couple of months. I became almost invisible to everybody down there because my life became just completely involved with what was going on with this virus and what our health system was doing. I'm at Barton Health, which is it's an independent, not-for-profit rural health system in South Lake Tahoe. Been around for 57 years, named Barton for the family that donated property. And we take care of our community, which can be fairly isolated at times. We're not too far from Sacramento, and we're a little bit closer to Carson in Nevada and Reno, but there's times in the year when we are like an island and we can't even transport to those locations. So Barton is made up, the health system has many outpatient clinics and an ambulatory surgery center, as well as an acute, Barton Memorial Hospital for acute care, 63 beds, so not big. But we're attached also to a long-term care facility. So the same facility has some skilled nursing, and the long-term care, we have about just under 1,000 employees. And so our concern initially, obviously, we've got with that long-term care, we've got 43 residents there. And as I just saw today, there have been 32,000 deaths across the country among residents in a similar scenario. So that was a big concern. We really are here for our community, but tourism adds a lot to what we do. And as you know, we've got Heavenly and Kirkwood and a lot of outdoor activities. We far surpass any national park as far as the number of visitors that we get in a year. And so that's wonderful for us in some ways, and it's also increases our risk quite a bit in a pandemic. We started talking about coronavirus in January, this novel coronavirus, and we had a soft opening of our incident command the very end of February with the first US case, and then fully opened our incident command system in the first week of March. So we were a little bit earlier than many others, and instantly put forward a drive-up care, knowing that how infectious this virus was. We opened a closed clinical building to evaluate our emergent or non-emergent patients who had COVID-like symptoms. And that made a big difference, as well as immediately went to telehealth. And this is something I think it's very similar to all the systems that you're a part of. I think we found that we could move so much faster with the what pressure the pandemic was putting on us into a different type of environment and different workflow than would ever been before. What would have taken months ended up happening in hours and days, it felt like. So a tremendous amount of work. We were concerned that if the whole, as everybody was, if the whole system around us were inundated, that we would have to care for our patients ourselves. And we built a surge capacity by 100 beds. We added 100 beds to potentially to our facility. It was helpful that Vail, who runs the ski resorts, shut down early, and that made a significant difference for us. We're glad that that occurred. You know, one of our earliest patients was one of our staff members. Husband had worked at a bar as a bartender and was symptomatic first, and then she became symptomatic, and she was also pregnant. And so this is mid-March, when we're trying to deal with in-term pregnancy, what would happen were she to come in actively with the virus. And of course, early on, we're trying to learn about what this means, the positive test, how long will they be infectious? She had one negative test, and at that time we were looking to get 2 negative tests. She had a negative test before she came in labor, and then we received the result of the subsequent test that was positive again. And so our staff kind of going back and forth, of course, they were wearing PPE throughout, and things worked out, but that patient individually she continued to have a positive PCR test out about 6 weeks. So with that, you know, we had to learn and maybe adjust how we were doing things, as everybody did across the country and the world. Following the science updates was a real challenge for us. And this is, I'm sure, the same also for all of you. We formed a core group of physicians from different specialties that could analyze the information that was just coming in this rapid flow and make recommendations as we went. Droplet versus airborne precautions being necessary. And as we learned that airborne was certainly played a role in many cases, we transitioned our facility that had only 3 rooms before all this with negative airflow into where our complete facility, the med-surg ward, our ICU, and our emergency department became negative flow, which is a tremendous engineering feat that occurred in a matter of days versus what would have taken months. So just, you know, all of that was a bit overwhelming. PPE, of course, was a challenge for everybody. We were concerned as a small out-of-the-way system that anything that got released from the government would go quickly to you, Bill, and you others at larger systems, and we would be left out. And certainly went many weeks without any supplies, had to be very smart about how we used our supplies. We even got to the point where we were wearing cloth masks, and the community effort came in, and the community was making cloth masks for those who weren't actively caring for infected patients as a means of source control. And it wasn't until we got a resupply of some masks that we were able to move back to your typical surgical masks as needed. We had designed to be using a capper system for our airborne infections, and that became overwhelming quite quickly, and had to move to N95s and testing, and all of that happened in short amount of time. Fortunately, we've had no transmissions from staff to patient or patient to staff. We've had a couple of instances where staff members we think could have gotten each other infected. Overall, the testing, we also had, we've been testing asymptomatic community members up to 130 a day at our community college. And up to this time in our county, now El Dorado County is what I'm referring to. We also, half of our community is on the Nevada side in Douglas County, but the El Dorado County is where Barton sits physically, just a few miles away from the Nevada side. But we've tested 7,000. We've here in our area have had just 48 positives, not a huge number. We've had some serious infections that I think had we been back in March, they would have been intubated, but we were able to manage things without intubation. And in fact, two of our more serious patients who've been here for a couple of weeks will be going home today. So we've not had any deaths. We've not had an intubation at this point, and that's been very good for us. We started testing all of our pre-op as we're opening up and doing more surgeries again. We're testing all of our patients, and just this weekend had our first asymptomatic positive patient pop up right before today, which was his surgery date. So I had to move back the surgery as we work on this. And this is affecting every one of our service lines, including, of course, anesthesiology and our surgery folks. So a fair amount of complexity. And you know, every case is a little bit different. We've had a hiker brought in with just GI symptoms who was up in Desolation Wilderness. Would have never thought that it was a COVID, but ended up being positive. And fortunately, we're using PPE throughout. Had a 2-month-old be brought in who was sick, had an underlying pulmonary and cardiac condition, but was infective, had some type of infection. And so we had to work with Telehealth and UC Davis partners to stabilize the patient in our ED while we were wearing full PPE. And when I say we, I wasn't one of them, but people going in and out of the room had to learn how to do that effectively to stabilize that patient, intubate, and transfer down back to Davis, where the baby had been when she was first born. So a lot of interaction, a lot of telehealth. It's been quite a journey. I know that my time was just 10 minutes and I've probably overdone that. But I appreciate being able to share that with you. And if there are any specific questions, then I would be happy to answer.
Thank you, Matt. We really appreciate that. We're going to, because of time, try to hold the questions to the end. So if anyone has a specific question for Matt, you can put it in the chat line right now and Matt could answer it immediately, but otherwise we'll hold the overall questions till the end.
Great. And moving on, was that Dr. Zahir next? I believe, no, it was Carol Peden. Thank you. And I apologize, I wasn't quite ready, but I appreciate the opportunity to introduce Carol Peden to the group. And Dr. Peden, who works at the Keck School of Medicine, where I finished a brief physician leadership course there last year, so I appreciate having a USC diploma on my wall. But Dr. Peden is, as you can see, is doing much work in a variety of areas. It's quite impressive. And Dr. Peden, I will turn the time over to you.
Thank you. Thank you, everybody, and fascinating talks, as usual, on the University of Best Practice. I'm going to talk about disruptive innovation in the time of COVID-19. For those of you who may not be aware of the term, it was coined by Clayton Christensen, who was a Harvard Business School professor, and is thought to be one of the most influential business ideas of the early 21st century. It essentially refers to disrupting major business, or in this case, healthcare, which is very settled in the way it delivers care. Often smaller, innovative ideas and companies come up and stir things up. And in our case, it's been COVID-19. So that's what I'm going to talk about. Next slide, please. I'd like you to think about why things have changed so dramatically. Some of it's obvious. I know the speaker after me, James Marston, is going to talk about some of the incentives to change and some of the barriers. And then I'd like you to be thinking at the end of this, if we can do, for example, telemedicine so fast and so quickly and so differently, what else can we do differently? On the last Los Angeles University of Best Practice, we heard a lot about home blood pressure monitoring, how effective it is in reducing blood pressure and also cost effective. So why aren't we all doing that? And that runs into how do the changes that we've seen help deliver our University of Best Practice goals. Next slide. So as you've already heard, healthcare has changed dramatically in the space of a few weeks, thanks to the virus you can see here. Next slide. And this is the things we've done at Keck Medicine of USC, and very similar to most other centers, and in fact, indeed, around the world. We've adapted our facilities. We scaled up very rapidly to meet surge capacity, which fortunately we haven't seen a huge amount of in East Los Angeles. We developed triage and testing. We looked for personal protective equipment. We developed Care for the Caregiver program, and we rapidly expanded our telehealth capabilities. Next slide. Just in the PPE, we worked very hard early on to get it. And one of the things we found was that going into this pandemic, there was a lot of anxiety because we were looking at Italy and other countries and hearing about the difficulties in getting PPE. So we started publishing every day. And these numbers on the right of the slide are the numbers of days we have going forward of N95s, gloves, goggles, shields. And that helped alleviate anxiety amongst our staff. And I think it's something we'll use more going forward, really transparent publishing of what's going on in the organization. Next slide. We worked very hard on care for the caregiver, recognizing that anxiety. And again, this is something that we would want to keep going. We did comfort kits, we housed our staff, and made it feel very personable that not only were they caring for sick people, but we were caring for them. Next slide. And again, you know, music as medicine, legal assistance for people that were struggling, emotional well-being programs, and this sense of community and celebration, important in any effective organization. Next slide. And this is one thing that benefited us early on. We're a member of a group which emerged out of a project called Global Comparators. It's now called Global Health Data at Work. We're part of a global network of hospitals, including Humanitas Hospital in Italy, where my colleague from London, Maurizio Ciccone, is now the head of ICU. He was named JAMA, one of the Time Heroes of the Year for his response in the COVID pandemic. And because we were in this network very early on, we're hearing frontline from them what they were doing. And so we introduced, for example, masking for all personnel in the hospital way back, probably very early in March, because of this ability to be ahead of things. Next slide. And this is just showing our network and the fact that, next slide, that we meet regularly, colleagues from the UK there, the Netherlands, Italy. It's been very, very helpful. And I think that's something we should think about going forward. How do we look around and see what others are doing and take those best practices when we're no longer in a pandemic? How do we do that on a regular basis? Next slide. So we've had a burning platform to make change happen. But again, I want to challenge you. When we don't have a burning platform, why and how do we innovate and think differently? And not be complacent about how we're delivering care, because that's the way we've always done things. Next slide. Interestingly, we at Keck had been partnering in the Leadership Alliance with the Institute for Healthcare Improvement on something that was called The Office Visit is a Dinosaur, which the acronym was OVID, one letter short of COVID, of course, so perhaps prescient. And I think COVID has been the meteor that has wiped out the dinosaur of our goal with this project was to do 10% of our visits on telemedicine. So you can see this, that goal has been literally wiped out and we're in a new universe. Next slide. And this is just something we just published, I think it's online today actually. And we really scaled up quickly. Of course, the stay-at-home order for California was March the 19th, but we saw it coming. But the reason we could scale up fast was we already had a telemedicine platform in place. So we just needed to activate things, but that required innovation. How do you train people when everybody's at home and your trainers are at home? But you can see the scale of the takeoff there in the use of telemedicine and televisits. Next slide. And next. And you can see, again, we've sustained this. We launched 88 new clinics, trained 600 providers, et cetera, et cetera. And the next speaker is going to talk more about this. But we can do it when we have to. We'd been talking about telemedicine, but we'd managed to do things very, very slowly. So suddenly we can do things differently. Next slide. So again, a slide from IHI. This has changed things dramatically. And I really hope that we can hold on to some of this going forward. And as I think the next speaker will talk about, refine what we do to make it really effective. Next slide. Here's something from Becker's Health, which is talking about this is healthcare's Amazon moment, that we have been challenged, we have to do things differently, and hopefully good things will come out of this. Next slide. So he talked about things he thought would be important, more partnerships between health systems and health payers. Well, I can tell you many of the health payers, such as United, have been very interested in telemedicine. They want their patients to be found early before they become sicker, treated effectively and more cost effectively. Data and AI will be important. How patient data is handled, that building that trust. And this is one area I'm very concerned about, that we make sure that we actually build technology for patients that are less tech literate and have less access to technology. And then skills in physicians. I don't know how many of you have actually done a visit yourself or received one. You're face-to-face on the screen like this. And so that sort of empathy is in a way emphasized. And so that may be more important. And I would also understand the ability for physicians to understand and use data more effectively. Next slide. You've seen doctors become very innovative. This is just a slide, you know, I'm an anesthesiologist. How do you intubate without spraying the virus everywhere? So rapid innovation because of necessity. Next. And we've already mentioned the use of iPads and technology to connect patients and their families when the family can't visit. But again, I would challenge us. Many of us live distant from our family and friends. Why weren't we making this kind of technology more available before the pandemic? iPads have been in use for a long time. We use them all the time outside of the hospital. Why weren't we better at doing this in the hospital? Next slide. Disruption was already here. This is a company called Babylon that many of you may have heard of. It has already taken a lot of the primary care practice in London. It's been working with the National Health Service in the UK, primarily taking the kind of patients that big academic health systems like, or payers like, the young, fit patients who don't want to visit a doctor normally. But this disruption was already there, and we were all thinking about it. But again, they're primed to do more unless we change. Next slide. So why disrupt the status quo? Well, I think I've given you some ideas, but we need to be more patient-centered. We never really valued our patients' time. And as you know, that the challenges of driving, particularly in Los Angeles, to a hospital, finding a car parking space is very significant, but that was never costed into the care of the visit. So that's just one example of why we needed some disruption. Next slide. But again, this is central to our mission here. 1 in 4 deaths from heart disease and stroke in the US is preventable. Data that's a few years out of date now, but in my area of patient safety as well, 1 in 20 harms are preventable. So there are definitely things we need to do better and more cost effectively in preventing them. Next slide. Physician burnout is an issue and has been for some time. One of my telemedicine colleagues or primary care colleagues said she thought telemedicine may help in this burnout because it seemed more efficient and it's more personable. You're looking directly at the patient rather than looking at a computer. Next slide. And next. And then of course there's cost. You know, the United States has a very high cost healthcare spending, and particularly when you relate that to outcomes, the spending is very, very high without necessarily better outcomes than other countries. So we have to think, how do we deliver care that's not only effective, but is personable, but is cost effective? Next slide. And this is a review of what the top challenges affecting all healthcare systems are, I think from Davos. Next. Shifts in population demographics and social characteristics. The increasing oldest old, those patients who are over 85, the fastest growing group in Western countries. Social characteristics will be more people working at home, less willing to travel. Next slide. The balance between containing costs while maintaining access and quality. Next slide. And fragmented healthcare delivery models. And again, these are things that I think we have a rare opportunity now to really stand back and say, well, we could do something very differently, very fast. How do we use that momentum to really think through how we change care delivery? Next slide. And also the concept of value in care. Michael Porter's work, a very important article if you haven't read it, value defined as health outcomes achieved per dollar spent. And also the concept of what matters most to patients. Again, if we are to be redesigning healthcare, we need to really think about those concepts as we're doing it. Next slide. Secondly, do we just do small improvements, or do we completely redesign care? Can you do both? And I think with this sudden move to telemedicine, we've done radical redesign. But going forward, we need to think about, where do we just need to tweak, and where is just tweaking how you do things not enough? You need to completely change your model of care delivery. Next slide. And what is the difference between innovation and improvement? Something to think about. Next. Generally, I think innovation has more risk. It's creative, it's challenging, and it's probably more customer focused. And there can be pathways for innovation. Improvement is safer, and really what we've been doing often up until now. It's safer, it's slower, it's more focused on refining what you've got. So optimizing evidence-based practices. Next. And how do these different concepts, disruption, innovation, and evolution, apply to healthcare? So thinking about what could be improved, where do you need to innovate, what requires truly disruptive change? And one example that's often used is the concept of the waiting room. Why do we have patients waiting? Why is that tolerable? And I don't know, again, if any of you have actually experienced a telemedicine consult, but if you're the patient waiting with just a blank screen, a 5-minute wait seems very, very long. Whereas in a waiting room, you can at least read a magazine. So how can innovation and improvement partner? So again, these things that we need to be thinking about, not just in relation to ambulatory care consulting, but throughout all our pathways of delivery. Next slide. And then improvement science is about bridging the gap between knowing and delivering. So thinking not just about change, but why change is happening, going back and studying it. And in relation, if we're thinking about telemedicine, who benefits most, who does not benefit? What about bridging that digital divide between the patients who may be less technologically savvy or may have poor internet access, for example? Next slide. So in my experience, improvement work drives innovation, because to improve, you need to fully understand your system. You need to know the psychology of the people working in it. You need to know how the system flows and how it works. And then when you truly understand it, you may say, this isn't enough. We need to change it completely. But you have to get under what works, what doesn't work. Next step. For those of you who haven't read Atul Gawande, I'd suggest this one is an easy read. And he talks about slow ideas and fast ideas. And I think we have now shown that telemedicine's gone from a slow idea to a fast idea. In this particular article, he contrasts the first public demonstration of anesthesia, obviously in Boston, but 10 days later, 10 days in 1846, 10 days later in London. So very, very fast innovation. And why? I would suggest partly, and he does too, that it made a difference to the surgeon and the operator. So there's, again, whenever you're thinking about improvement or innovation, you have to think, what are the benefits to everybody? What's the benefit to us as a provider? What's the benefit to the healthcare system? And what's the benefit to the patient? The slow spread, sadly, was antisepsis, which, I'd be very interested to see some of the other infections in our hospitals, such as C. diff, in this time of COVID, when we're now washing our hands very, very effectively and all the time. Next slide. So getting ideas, educating teams on how to make their ideas happen. Next. What you don't want to do is to have this approach where I've been here one day, I've seen something that could be done differently, and you get the splat. This is how we've always done things around here. So we need to be working with teams, working with our patients, constantly asking, what could we do better? How could we do things differently? What are they doing over there? What are they doing in Italy that we could learn from? So constantly challenging ourselves and bringing those new ideas in. Next slide. So we need to, this is think different. This is a Steve Jobs term. Broaden our focus and look outside. Study improvement science. Understand reliable delivery of care. So why don't patients after a heart attack always get drugs delivered reliably? How do we involve patients in care design? And I think this is critical, and one that we often haven't focused enough on. Next. So Steve Jobs' concept of think different. Next. And he talked about doing, and this is an important part of innovation and improvement, work on things that you're passionate about. Really find what interests you. Where do you want to work? What sometimes with innovation and improvement, what's a real pain in the neck in your life, that in your working life, that you could make better, because it will probably benefit everybody. Be different, think different, look at strengths, weaknesses, opportunities, and threats, be entrepreneurial, learn continually, and learn from failures. We have, because of necessity during the COVID pandemic, we've scaled up rapidly, and we've rapidly learned what works and doesn't work. In true PDSA, Plan, Do, Study, Act cycle way, we've done it fast, and we've been willing to learn because we had to challenge ourselves. Next slide. And then for those of you who may have seen the Choosing Wisely campaign, ask why 5 times in lean terminology. Why do we do this? Why do we always X-ray for such and such a thing? I mean, a good example in my world is routine preoperative chest X-ray. There's no evidence for it, but often we do it. So keep asking, why do we do this? Can we do something different? It's a really good concept. Often medical students ask great questions. Why do you do it like that? And you think, why do we do it like that? Next slide. And then thinking about the barriers to innovation, which I know we'll talk about in the next talk. What's stopping us doing things differently? One of the things in the US has been payer, and we've said, the payer, there have been payer challenges about delivering telemedicine. But in my home country of the UK, they weren't doing telemedicine either, and there was no payer challenge. And they've changed dramatically just as we have. So sometimes our excuses are not relevant when we're really challenged. Next slide. So this is from Naomi Fried, but it's, the idea again about initiate your idea, pilot, operationalize it, and if it doesn't work, obsolete it or repeat with some changes. So it's the PDSA cycle of implementing change. Next. Where do you affect change? Now, these are slides from different angles of the Disney Concert Hall in Los Angeles, but inside it looks very different to outside. So where do you impact change? Is it at the patient and provider level? Or is it at the system level, which in the case of, say, telemedicine has to facilitate those changes? Or in this case, is it macro level, at a governmental level, which put in or decrease the regulations in order for us to effect change? If you can get those 3 things lined up, the micro, the meso, and macro system changes, as has happened with telemedicine, then you can really effect change. So when you're thinking about changes, think about, does this have organizational support, or is there a national drive to do something different? Another example is reducing opioid prescription. There are micro level requirements, interaction with the patient, what's best for the patient, but there's also macro and meso level support for that. Next slide. And just be aware that things do look differently from where you are in the system, and you will have to do things differently. Next slide. And next. Next. So I think, again, when we're thinking about, are we working at a high governmental level or at a very central level with the patient, if we keep the patient as our focus, that is always grounds us to where we should be. And really important article from the Dartmouth group on clinical microsystems, the building blocks of health systems, and keeping the patient and family co-design centered. Next. So just some other examples of innovation. We've talked a lot about telemedicine. I'm not going to play this now, but one example that my colleague Tom Downs in the University of Sheffield in the UK did over 10 years ago, the concept of flipped discharge, particularly for the fragile elderly. Instead of admitting a fragile patient to decompensate in the hospital, take care home to them, take them home and treat them there and evaluate them there. Also, the hospital at home programs that are going on. One thing I've been very involved in, enhanced recovery after surgery, challenging the traditional paradigms of surgery, giving patients clear fluids up until 2 hours prior to surgery, getting them up and walking straight after surgery, all those things that for many, many years we thought were the norm, and now we find we can do differently. And then, just as I say, think outside the box, look around at industry, look around at what the rest of the world is doing. Take the best ideas, still shamelessly, as my colleagues at IHI would say, and use them in our healthcare. Next. So doing things differently can be delivering care differently at the patient level, at the hospital level, at the national governmental level. We can have new kit, we can have new technology, we can design how we do things differently, and we can behave differently. And then we can use sites of care delivery differently. We have all these things that we can think and really challenge. And this is an opportunity from this pandemic. The people, the places, the things, the way we've always done them, do we always need to do them the same? Next slide. This is going back to New England Journal of Medicine Catalyst a couple of years ago, talking about what's technology going to be good for. And number one was support patient in effort to be healthy. And down the bottom, augment current capabilities of bricks and mortar health system. I think maybe that may be completely changed around now. Next slide. And this is something that Leslie Saxon, cardiologist here, and I wrote about, again, a few years ago, something I'm very passionate about. We really need to think about how we make technology available for the very elderly. Carol Zaher and I share mothers in their late 80s, early 90s who are not technologically literate, but who desperately need to be connected with because they're basically locked in during this pandemic. So we have to think about those super elderly patients, the fastest growing group of the population, and how we help them, and also with different languages and different internet access. Next slide. So I think hopefully we are entering the digital age. This is challenging us to think differently, how we monitor patients at home, as Dr. Margolis talked about in our last UBP, how we treat blood pressure at home, and how we bring all that information back to us and make our care more effective and more patient-centered. Next. So finally, I think there's a number of central important concepts for innovation and improvement before and after COVID-19. Hopefully there is an after. Reduce the variation in the way we do things, build reliable processes, design our clinical systems and focus on need, truly involve patients and partner with them, not just when we've designed something and asking them what they think of it, but get them involved at the beginning in the design. Care for the caregivers, I think, shouldn't be something that's just here short term. We should really think about our healthcare workers, and not just nurses and doctors, but those essential people who are very important when you're a patient, who bring you your food, who clean the floors, absolutely essential. And then that culture of openness, transparency, multidisciplinary, and celebrating success and creativity and being happy. So on that note, thank you, and I'll hand back to the chair.
Dr. Peden, thank you very much. I love the Disruptive Innovation title. I think that's fantastic. I have to admit the talks today have been very invigorating and exciting to me. And although much more technologically oriented, I think it reminds me, for those of you who remember the movie MASH or the television series, maybe this is our new MASH, where we have to really get out of our typical box and create a new one and be as innovative as we can to meet the needs of an emergent situation. So thank you very much. We're going to save the questions till the end so that we keep pretty much on track. And I'd like to introduce now Dr. James Marson from the Pediatric Critical Care Unit Director at UC Davis. And he's going to talk about more telehealth for the era of COVID, which has really, as mentioned earlier in the talks, has found its home now. Dr. Marson, are you there?
Yes, thanks so much. So just a quick note to Dr. Baumer and Dr. Peden, those were great talks, and I think that there's a couple of questions in the Q&A and the web chat for you, although I'm tempted to answer them. I'm probably, as a pediatric critical care physician, I'm not the right person to do so. So thank you very much, everybody. It's a pleasure and honor to be able to share what's been going on in telemedicine, kind of nationwide here in the state of California and here at UC Davis. And I know that there's a variety of folks listening in, and so hopefully I'll be able to touch in all of your areas of interest. Next slide. So I think now these are all of a sudden big terms, and actually one of our publicists or folks here working in our Center for Health and Technology at UC Davis here was looking, and you can look on Google the search terms, what's more popular, and compare different terms. And telehealth, interestingly enough, even though I've been doing this for 15, 20 years, I've always liked the term telemedicine, but telehealth is kind of replacing that, at least in terms of the Google search terms that way. But you'll also hear digital health, virtual health, e-health, m-health, lots of different terms thrown out for those of us that live in these worlds are a little bit different, but the whole concept, I think, from our standpoint, whether it's looking at telemedicine or telehealth, the definitions of this is that you're just providing healthcare over a distance using some form of telecommunications technology. Next, hit the next, please. And so I know that folks, different people categorize it differently, and this is kind of an old classic way of looking at it. It started off with old live interactive video, and hopefully I won't get sued by the Jetsons here, where you're just doing live interactive video healthcare this way. And it was primarily brought out giving services to folks that live in rural and underserved communities from regional centers of expertise like you might be providing. But slowly there's been an addition or expanding of these balloons of healthcare that are provided over distance, and the overlap is becoming more and more. So store and forward, of course, or asynchronous, and that's teleradiology is a big example of that, but increasingly is teledermatology, teleophthalmology, and even things that hadn't thought to be amenable to store and forward, like telepsychiatry or telebehavioral health, are starting to expand that way. Another category is remote patient monitoring or chronic disease management. Again, we've heard a lot about this for folks with chronic conditions at home, how we can better passively and actively monitor those patients and keeping them healthy and out of the hospital. And kind of a fourth category is this direct to consumer or direct to patient. A lot of people try to call it, where folks are able to communicate with their provider either with the swipe of a credit card, if it's to a third party for-profit company, or with a couple of additional steps if it's to your regular provider that way. So, and again, all of these are expanding rapidly. And to be honest, even though kind of number one started it off and then number two came into play, it's really number 3 and 4 that have been expanding most rapidly recently. Next slide. And if you hit next again, so the whole premise behind why even telemedicine is that we have built our healthcare system based upon regionalization, and we know that that improves efficiency and quality. It doesn't make sense to have a trauma center on every corner and every different hospital. Regionalization improves efficiency and quality. The unfortunate side effect of this is that we create disparities in access. And so the whole idea, I think, that telemedicine developed out of is that rather than folks having to come to the provider, as is shown in the lower left there, all of a sudden allows this otherwise regional expertise to be disseminated to whatever hospital, to whatever clinical, no matter how rural or isolated you might otherwise be. Next slide. So our overriding principles that we have, and again, this is a common, I think, among folks that do a lot of telehealth, is that it's not about the technology here, right? Telehealth is about workflow and operations, and I think Dr. Peden had alluded to this for sure. It's a care delivery model. The medicine should be the same, right? Whether you're treating a patient in person or over video or monitoring their data remotely without having to talk about them, it's about the medicine, and the technology shouldn't be driving what you do or when you do it. It should be a tool that is leveraged for you to be able to provide better care that way. And then sometimes the appropriate comparator, you know, if you think about the alternative, a lot of folks that study telemedicine say, well, do you get the same care that you would otherwise if you came to see the provider? But in a lot of cases, it is care that otherwise doesn't happen. And so you could argue that it doesn't necessarily, what you're doing doesn't necessarily have to meet the equivalence of in person, because it's a new model of care. And if this patient who lived in a rural location 4 or 5 hours away wasn't otherwise getting the care, then it is indeed a big improvement. There's lots of things, the very concerns that typically older docs like me that say, well, you can't do the physical exam. The patient wants to be in my stinky waiting room and come in to see this. And the more that this is researched, actually, the less likely we think it is to be true in certain circumstances. You are able to evaluate a lot for physical exam. You're able to see them in their own environment, in their own home, things like that, things that you wouldn't otherwise get if they came. You know, this is last week, a pediatric endocrinology colleague was telling me about a patient that she was seeing, one of her teenagers with diabetes, and she said she didn't realize that she was homeless. She was coming into the clinic every 4 times a year. All of a sudden she sees that she's in a tent, and that wouldn't otherwise be noted if she wasn't using telehealth. And clearly there are circumstances where the in-person is necessary, and the goal is not to lower the quality of care, or lower the standard of care, but augment the standard of care. And if they need to come in, we never force patients, and I don't think that this should be done, to do telemedicine when they want to come in person, or have a provider do something over video that they may not be comfortable with. If they want the patient, if they feel that it's necessary to have the patient come, then they should have the patient come. And again, so the overall long-term strategy should not be sacrificed. Next slide. And again, these are folks that do telehealth, and you know all of this, and these are common things to go over, but really quickly: access, distance barrier. You'll see that, again, we used to think that it was all primarily for folks living in rural and isolated communities, but the urban patients use this technology a lot. And while there's practitioner shortages, it's, clinicians are already busy, so having them do telemedicine on top of what they're already doing isn't necessarily a solution. But if you're able to leverage the technologies to be more efficient, to help keep people more healthy before they have to come in, and help use the healthcare team rather than just relying on the physicians for everything, I do think that it can add efficiencies this way. And again, as the previous speakers had mentioned, this is very patient-centered and more convenient for consumers. The reality is most patients, if it's just a follow-up or a post-op check or a check on a medication change, they don't necessarily want to have to come into you. They don't necessarily have to walk into a psychiatrist's office with a sign and drive in and be in the waiting room that way. A lot of times they just prefer to do it in the privacy of their own home or wherever they might be. And it's also been studied in a lot of different realms where it actually results in higher quality of care. The old days of sending a patient to a specialist and then going back to their primary care provider, and that primary care provider not being involved with those decisions decisions, not necessarily knowing why the specialist made those changes or recommended those changes or waiting for a letter. That's inefficient. And if you can get all three of those people, the patient, the specialist, and the primary care provider in one room, one video consult, everybody's on the same page, and it really strengthens the delivery of care in the medical home that way. And then value, cost of care. And again, this is not maybe by increasing access, you might increase costs by increasing utilization. And a lot, it has to be researched here. But those of us that do this, again, we really strongly believe if used appropriately and leveraged, it can reduce overall healthcare costs. Next slide. So if we're here a little bit about UC Davis, we have been doing this a long time. It's consistent with our mission. We have been providers of rural and underserved communities for a long time. A lot of the folks that we train here go on to be primary care providers in rural and underserved communities. And we've maintained a mission to dedicated to creating, researching, and implementing and teaching new models of care using technology-enabled clinical services. Dr. Tom Nesbitt, he started our program down in the lower left, and our assistant dean, Janet Katz-Bell. They've been doing this for 5 years longer than I have. And then kudos to our vice chancellor and CEO, Dr. David Lubarsky, because I tell you, when you have a leader that has a vision on how to transform healthcare, it really gets all the way down to the roots of the health system. And Dr. Lubarsky has been, it used to be that I would just sit back and complain that we should be doing this and we should be doing this, we should be doing this. And he joined our team about a year ago and he was like, "You're right, Jim, why aren't you doing this?" And all of a sudden my life has become a little bit more difficult because I actually have to do all the metrics that he's wanting me to get. But it's been amazing to have leadership, which is my first point, I think, about having leadership that envisions this transformation of care. Next slide. So this is the way we categorize our service at UC Davis. And again, it's not the right way. Other folks have different buckets, things like that. And we have some very good, strong strengths and buckets. Other places have stronger buckets like this. But over on the far left, this is where our specialists provide subspecialty consultations to outpatient clinics when they go to their primary care provider, be that a community health center, FQHC, rural health center, hospital-based clinic, things like that. And we have 30 different specialties doing this to approximately 80 different sites in a given year. We also provide specialty services to other hospitals. So if a patient comes in, a common one is for telestroke, but if a patient's admitted to a hospital and they don't have that subspecialty available, adult neurology, pediatric allergy, pediatric pulmonology, whatever it is, our subspecialists, rather than transporting the patient to us, we transport our specialists to that to raise the level of care that's being provided in that outside inpatient service unit. We also have inpatient telehealth services internally. And again, Dr. Baumer gave a slide about this where we're using it to bring in interpreting services. We're having it connect to families. Our parents can visit their baby if they're in the NICU using video, team-based care, bringing in family-centered rounds, family engagement that way. We have another category where we use Epic here as our electronic health record. So the MyChart video visits, outpatient, these are scheduled. And again, that's where the exponential growth has happened across the country, not just here at UC Davis. The use of e-consults, right? So for provider to provider email questions on patients rather than initially going right to the subspecialty consultation or the referral that way, you do kind of an email exchange on what you might do with this patient. There's been lots of, this of course have been done very well in LA, in the Bay Area, to help increase access, education, and efficiency of utilization of subspecialist services. Then there's also urgent or acute care video visits. A lot of this can be farmed out. There's third-party companies, as you know, Teladoc, MDLive, Doctor on Demand, American Well. There's a whole gazillion of them where you can get on a device and connect up for an urgent care visit with a provider who might be in a different state for that matter. And then the second from last from the right, the remote patient monitoring and chronic disease management. Again, this is patient-generated data, passive and active collection of data, mostly with comorbidities like diabetes. Why is it that we wait for the patients to bring in their glucometers when we can be actively collecting that data passively without them even knowing about it? Scales, congestive heart failure, pulse oximeter, ICD, pacemakers, all of this stuff, we can do a better better job at making sure or identifying folks that get sick before they end up in the emergency department. And then the last one on the right is, I think, what I do a lot of work in, but at UC Davis as an academic health center, is really researching these technologies and trying to idea development from the brilliant junior faculty that we have here that have come up with an idea. Why are we doing it this way? Again, like Dr. Peden had mentioned, that they come to us and we help them develop these innovative ideas, whether or not they go on ultimately to production. Next slide. So we consider ourselves, and again, not that this is the right way, a matrix organization. So the CHT is a Center for Health and Technology, and that's what we have in the middle. But it is super important, just again, delivering healthcare, that we do not work in a silo, but we work with our partners, legals, contracts, compliance, clinical operations at the PCS's, patient care services, medical staff, privileging, credentialing, cross-state licensure, how this is integrated into our medical record, Epic, health information management, our PBGs, our billing group, things like that, the codes, make sure that the documentation is all of there. And then we have kind of like a think tank area called the Digital Health Resource Center. And we have, probably too many meetings, and it's Zoom meetings now with all of these different teams. But that's what we have found to be most successful. It is not just a telemedicine department or somebody given 25% or 20% here or partial people, but it's true partnerships with everybody that's working in the health system or the clinic that way. Next slide. Again, I've kind of mentioned this, I'll go through this quickly, but we consider ourselves here in the CHT kind of in the research QI, the ideation and concept design. We work in our Digital Health Resource Center with folks from IT, the proof of concept validation. Some of those go on to implementation and full integration at scale. Others do not, right? So, but there's a lot of grassroots efforts from frontline clinicians that come to us that say, hey, we should be following up these patients with this, or hey, better bed management among our patient population can be achieved if we maybe think of or use these technologies. And we like to be able to foster those frontline ideas of the clinicians that way, but work very closely with operations. And then once it's in full operations, it's no longer ours. An example of that is the video visits, which I'll get to here, right? So we were under, just like Dr. Peden mentioned, we were under the same thing, like, hey, you should have 1% of your 1 million outpatient touches done by video. And we were struggling with that out of the CHT, but since COVID came along, that's blown up, and it's no longer in the CHT really. That's dealt with clinical operations now, as it should be. Next slide. So this is, with the kind of who or what. This is where I'm hoping that we had participants able to give me your answers on this, and we could see how this compares. Who or what was the greatest driver of telehealth at your health system? So the next one, was it your chief executive officer? Your next one, was it your chief information officer? Next one, is your CMIO? Who is that? Next one, was it your chief innovation officer if you have one? Or was it answer E, which is that COVID? And I think most of us would answer E to this, despite having amazing CEOs, CIOs, and all of that, trying to get the ball moving on this. Next, it's kind of hard to do a joke like that over video, but so this is our experience here at UC Davis. Again, we had 50 doctors doing video visits regularly and routinely. We're trying to expand that. And again, it sounds like very similar to numbers that what Dr. Peden mentioned. Now we have more than 700 physicians doing it. And you can see in the lower right, that's up to April 1st. We're doing more than 1,000 per day when we were doing 25 to 50 a day. The only reason we were able to do that is we had invested in team and infrastructure and lots of IT and Epic. Had we not had that in place, we would have been in a lot of trouble like a lot of other organizations were. So we were fortunate, but we've also been able to do it in the institution, same-day video visits, as mentioned, bring in our interpreters so that we have three-way calls, inpatient telemedicine. We're using it in our research efforts to consent and enroll patients. And it's becoming more and more, as it should be, and hopefully will stay a part of normal operations. Next slide. So this is another graph of that. And you can see from this graph that they're starting to tail off here. These are the number of video visits per day, right? And so they're starting to trail off as people come back to in person. Next slide. This is data similarly from all of the UC health systems. So I was at University of California, the Office of the President shared this data with me because we're all supposed to be reporting our ambulatory visits and video visits. And as you can see before COVID, and it drops off on the weekend per week, the number of in-person visits in orange, and then the video visit in whatever color that is at the bottom. And then there's been months or weeks here where video visits were greater than the number of ambulatory visits. So on average, the whole UC system on ambulatory visits was seeing about 60% of its visits virtually. That varied across departments. Our Department of Psychiatry, for example, went 100% virtual. They weren't seeing any patients in person. Our cancer care network tended to have a lot more, relatively fewer video visits rather than in person. And as you can see, as you're going back out, as the dust settles, maybe from this COVID, there's been a little bit of reversing, but hopefully it won't go back to what it was originally. The next slide is just another way of looking at this, where it's just a total number. So that you see, and that's the other thing is we've reduced the number of ambulatory visits, right? So this is a total number of ambulatory visits, folks not coming in, bigger proportion. And you can see in this last week of May where it's about 60% in person, 40% video visits for outpatient among all 6 UCs. Next slide. Okay, next slide. That's just another one as a percentage. Take it. And so for those of you that are familiar with Fair Health, not-for-profit that tracks CMS spending on telehealth claims. So they, pre-COVID, they had, of all the claims that were submitted to CMS, 0.17% of them were video related or telehealth related. And in the month of March, and we expect this to be higher, in April and May for sure, it was 7.52%. So like all of my in financial investments, there was a 4,346% increase annual increase in the number of video visits that way. And again, this is a very busy slide, but you can find this on Fair Health. I'm pretty sure it's .org. Yep, it's fairhealth.org, but it talks about the top 5 CPT codes. And in the lower right, it has the pre-COVID March 2019 compared to March 2020. A lot of them, again, are mental health, behavioral health related, acute respiratory disease, but whereas it was almost half mental health, there's been a spreading across the different conditions, as you can see post-COVID. But again, we expect this to be different when we look at April and May data. And then the lower right, again, as somebody who kind of started out thinking that this was going to be primarily utilized by folks that live in rural places. The fact of the matter is, 7.8% of the claims in urban areas, 4.3%. So relatively speaking, folks living in rural areas it's not like it's higher than it is in urban areas. And there's lots of reasons for that, depending upon where you're living, telecommunications, access to care, poverty, things like that, and access to specialists. But I'll touch a little bit on that a little bit later. Next slide. And this is from the National Association of Community Health Centers, again, the FQHCs and all. So this is, again, with telehealth, rural and urban. And I think that, again, most of it has been mental health, about 60 to 70% of community health centers. Now, this is as of June 2020. So this is recent data, a survey that they recently completed, that a majority of community health centers have access and are using telehealth. Again, it's mostly for mental health, but you can see the dispersion there. And if you have that, a majority of it is real-time video. I'll talk a little bit about, it's been tough for the community health centers here because, again, they have had basically, they haven't been allowed to do these video visits to patients' home. So they hadn't necessarily invested in the infrastructure to be able to do these types of video visits, unlike, the health system that I belong to at UC Davis, where we had that in place. And so all of a sudden having the switch turned on to say, hey, you're allowed to do telemedicine and telephone they've been able to do a lot of telephone visits this way, but it's just been, they were in a tough spot where they were told basically they were allowed to do it, but they just wouldn't get paid for it, to all of a sudden say, now you can do it. They didn't have the investments in that for the telehealth, the software, hardware, infrastructure to be able to do this. Next slide. So I want to kind of go quickly through this, but if you're familiar, there's been changes, of course, at the federal level, CMS, and at all the most of the state levels on. A lot of it is a lifting of restrictions. There has been granted some increase in access, like payment for telephone visits, equivalent to in-person, primarily for the community health centers to be able to do this. But a lot of it was just really silly, or I shouldn't say silly, but lifting of these restrictions that were in place. The first one, eligible providers and eligible services. So you had to be a certain type of provider to be able to get paid by CMS or Medicare. The originating site restrictions, so the patient, you couldn't bill, patient couldn't be at home and get a video visit pre-COVID, right? That was a restriction, and they had to be, if you wanted to do telemedicine from site to site, the site had to be, where the patient was, had to be in a rural area. Restrictions that way. Those restrictions have been lifted that way. Also lifting of the distance site restrictions. So now not only can the patient be at home, but also the provider can be home and for certain codes and certain circumstances. We've all heard about the lifting of technology requirements. So the waiving of the HIPAA enforcement. Hopefully, I think that, centers that may not have had something in place are taking advantage of, just whether it's using something like Skype or FaceTime or whatever it is, Facebook to communicate with their patients, I've heard of even that way. But ultimately, that should be returned to a HIPAA compliant platforms. There's lifting of cost sharing requirements, again, which the health plans have been able to do this, waiving or reducing of copays, which has been important. Licensing and credentialing. So, there's been the credentialing by proxy that's been in place for a long time between health centers, but there's also now the at least being able to practice across state lines is made a little bit easier. But again, that's still up to the state. An example is we see patients in Nevada next door to us, and we have to alert their medical board that we are going to be providing telehealth services to their citizens, their state citizens in their state using telemedicine. But we're able to do that now, whereas before we needed to have our provider be fully licensed and credentialed in that state. There's some more on the resources, but for those of you that are not familiar, there's a national consortium of telehealth resource centers. There's 12 of them across the country. Every state is covered by it. California has its own California Telehealth Resource Center. Granted, it's the biggest one, and it's catrc.org is the website for that. And California actually also hosts the National Center for Telehealth Policy. That's located here in Sacramento, California as well. So there are resources available if there's any questions about licensing, credentialing, policy, regulations, things like that. Next slide. This is where there will be an expansion for sure, the hospital home taking care of patients and chronic medical conditions. A big problem has been with our payment system, of course, right? We may not necessarily be paid to keep patients healthy. We're certainly paid to take care of them when they get sick. But we know that 25% of the population accounts for 25% of the costs on a national level, and focusing on folks with multiple comorbidities or chronic disease management will really behoove everybody, right? The patients as well as the healthcare dollar spending, if we're able to do these different technologies. And that's just a smattering of images of, everyone knows that all of this can be done at home now. Next slide. Those practices where it's $1 saved is $1 kept in your own pocket, kind of like the Kaiser system or the VA system. They have been big adopters of this model of chronic disease management or remote patient monitoring, right? So this is 45% of vets living in rural areas have been using telehealth. This is all pre-COVID. 20% in 2019, 20% of all vets have been using telehealth. And again, that our number at our health system was not that high. Now it certainly is. More than 1 million patients that they have, more than the 3 million visits on their VA Video Connect app. And they do a lot of remote patient monitoring patients, and they really feel that doing so has resulted in a reduction in hospital admissions. This was an analysis of data from 2016, where they were doing remote patient monitoring for a smattering of chronic medical conditions, and they felt that it really reduced the hospital admissions this way. Next slide. I mean, this is not only just for chronic disease management, but also for acute care, post-COVID. So we have talked about this. I know that some centers are doing this. We have not yet at UC Davis, but patients that might be ill, to go home, send them. I should have blacked out the vendor name on this, and do monitoring of these patients more actively to see when they should be coming back to the emergency department or come to see their PCP. Because these technologies are not necessarily the barriers. How to operationalize it is where the barrier lies, right? So there's wearables, there's kind of Band-Aid or tattoo types of things. They can measure your temperature, heart rate, respiratory rate, more invasive things can look at your blood pressure. They can even identify when you're coughing and sneezing by the reaction that your body takes that way, and looking at the frequency of coughs and the intensity of how hard you're coughing or difficult to breathe, that would alert, and for us to be able to better monitor patients either with suspected COVID or some other comorbid condition. Next slide. So I'm going to switch gears a little bit. I know that I talk a lot about like, hey, yay, telemedicine. That's what I do. And I'm a big advocate for it. But I also like to point out the fact that we need to do more research on this, because I've become a little bit obsessed in having done this for a long time on negative trials. This is one where this was published in JAMA, adults with that were overweight and obese at a BMI between 25 and 40, where they were given basically a Fitbit. And so this was a large number of patients, 470 patients. They all received low-calorie diet instructions, prescribed increase in physical activity. They all had group counseling sessions. And at 6 months, they gave half of them a wearable device like a Fitbit and showed them how to do it and their goals and things like that. The other half continued on. And this was a very good trial. It looked out at 2 years of data. If you click next, what happened at the end of the study? Well, those that were given the wearable device lost less weight. So the control group lost 6 kilos basically, and those that had the Fitbit lost 3.5. So I threw away my Fitbit because I think that is an interesting discussion about this, but people, and guilty is charged here, but you'd say, oh, I did 5,000 steps. I think I can have a second donut or dessert, things like this, how that interacted with them psychologically. But again, something where we think these technologies will help patients or better accomplish our goals. In this case, it actually did the opposite. Next slide. This is a California study, 6-center randomized controlled trial of a 1,500 patient with very severe congestive heart failure, UC Davis. And again, very well conducted randomized trial, usual healthcare with coaches and telephone calls. And then we had an intervention group that got their blood pressure with one of those blood pressure monitors, heart rate, symptom checkers that was put into the web, and a scale that was Bluetooth enabled. So we helped monitor these patients more closely with these technologies. And if you hit next, this was a basically negative trial. We thought that these technologies, we thought that this remote patient monitoring would improve care, but it actually didn't impact readmissions or mortality among this population. Next slide. And then the whole advent of direct-to-consumer care, right? So all of the major health plans, the 5 largest health plans in the country, all have access to this, either through a third-party vendor, or they create it themselves, so that if you're sick, you can get on your phone and be able to get in touch with the doctor. The idea being here that we're going to avoid a urgent care visit or an emergency department visit, right? And everybody has bought into this, even our health system. This is a little video. Again, it shows this child having their ear checked and having a very wonderful, everybody's of course Caucasian in the video they get their prescription, and the husband on the way home picks it up from work. Super convenient, but it is not necessarily in the best interest of the patient, nor is it healthcare within the medical home. Next slide. Go ahead again. So people have looked at this direct-to-consumer access care, direct-to-patient access to care. And one of the largest studies that's been done to date with thousands of patients, they determined that 12% of this type of access indeed replaced visits. I think it was 8% of it was determined to be emergency department visits, 4% urgent care or outpatient visits. But actually 88% of the use of these direct-to-consumer apps represented new utilization. So their estimate, this was done by the RAND Corporation, was that overall introducing this model of care resulted in increased healthcare costs. Again, so we have to be able to figure this out. We know that it's convenient for the patients. They want it, and in many circumstances, it's the right thing to do. It's to help patients out. But there's concerns about this technology as well. Another study here looking at adherence to guidelines. This is, again, I'm work in the pediatric world. For pediatric URI symptoms, they compared 4,600 direct-to-consumer visits to 3,800 urgent care to 485 primary care visits match. And the in-person visits were the best, right? They resulted in the best care. They had the lowest rates of antibiotics and the highest rate to adherence to evidence-based guidelines. Nobody was perfect. But again, and I'm not saying that they shouldn't be using these technologies, but we need some guardrails that quality of care is provided, that this care is provided within the medical home, that this information is shared with the primary care provider, or actually the primary care provider get paid for these types of services, and not necessarily be farmed out to some physician who may not know what's going on in your local community, which may not have access to your medical record, because they expect the patient to share this information with their primary care provider. But there's been research to show, of course, they don't share that, right? They don't want their primary care provider to know that they've been cheating on their doctor, and they didn't want to go and deal with them. They just wanted their antibiotics for their presumed UTI or otitis or URI. And so they go to one of these third-party platforms. Next slide. So another one, tele-ICU. I'm going to just breeze over this. If you click it one more time, Mayo Clinic did this study, thank you, with tele-ICU, and they didn't find any reduction in length of stay, any reduction in mortality. What they found out was that once they connected to the community ICUs that were in their area, all it did was result in higher transfers to the Mayo Clinic. If you click one more, I think. Okay, well, yeah. So all it did was increase transfers. So again, there's other studies that show this EICU, tele-ICU works. Some circumstances, not only does it not improve the desired outcomes, but it kind of led to less desirable outcomes. So as a researcher in healthcare, just to advocate and plug that we really need to figure out what we're doing, just because what we think might work probably or isn't necessarily going to be right. It's hard to tell egotistical doctors that. And NQF comes out with these domains. AHRQ has similarly come out with domains and opportunities for research, and we have to pay attention to these. Next slide. So barriers to adoption. Doug, I think Dr. Peden mentioned this a lot better than I do. People commonly quote reimbursement, licensure, things like that. But as Dr. Peden mentioned, there are some states that have had payer parity, other states that haven't. And yes, those states that have high payer parity, that is paying the same for video versus in person, yes, their utilization goes up, but it is nothing like anticipated or thought to be by the health plans in terms of breaking the bank. That didn't seem to be, the whatever it's called, the golden key or whatever, that would all of a sudden make telemedicine be utilized. Just payer parity, yep, it caused a little bump, but it didn't transform. It's like COVID did. The reality is that we are busy clinicians, whatever type of provider you are. So it's far and few between that you have a doctor going, I wish I could see more patients on my Thursday afternoon. I'm going to all of a sudden start doing video visits. They're already visits. So we have to do more than just offer this, but put it in the context where it's more efficient than current systems. There's lots of skepticism and fear about change. This is that coming from UC Davis. I would think that it is super important to have dedicated project management. Starting a telehealth program is like starting a heart transplant program or a liver transplant program. You don't just say, okay, you're going to do this on your side. You're going to get 20% here, things like that. It takes a lot of people, like I showed in that matrix organization, to be able to carry this effectively across. Technology, lots of things that I've already mentioned: funding, operations, long-term strategic plan. Next slide. So this is kind of, there's all these recommended ways of increasing the rate of adoption and the diffusion of innovation and things like that, and these methods to be able to make that more rapid. And I wanted to put a big splat of a COVID picture over this, because that's what really kicked all of our butts to be able to do this. But again, these are all very important issues to follow. For sure, you should definitely have these in place. This is called the 5 L's of technology transformation, and it can be used in the context of telehealth this way. But yeah, the COVID was a game changer. Next slide. And so again, my hope, my goal, my theory is that we are, this is an opportunity for us to really reimagine healthcare. Here at UC Davis, we have this restore, renew, reimagine, and we are beating the drums that now is a time. This has given us an opportunity, horrible pandemic tragedy, but this is an opportunity that we cannot let go, we cannot let slide by. We have to have our specialists maintain 10 to 20 to 30% of video visits. We have to be patient-centered. And these are the domains of this left on the left, the IOM, National Academy of Health, domains of quality of care. And I think that we'll be able to do this, I hope, now with COVID. We really, really hope that a lot of the restrictions that have been lifted will not be in place back. Some of them we expect, like payment for phone calls, but certainly like not the restrictions on the originating sites, things like that. So next slide. And I think that's it. So thank you very, very much for everybody and their time. And hopefully I didn't go too over. Thanks.
Thank you, Dr. Marson. Actually, you have 10 extra minutes if you'd like to fill it.
Oh my gosh, no. I felt like I talked way too fast, but I didn't want to bore people. So
No, that was great. Thank you. I mean, it sounds easy to say telehealth, and it sounds like it would make all our lives easier when we say it quickly. But I think you're right. We have to be cognizant of the fact that it is a little complicated from a lot of different angles. And we have to see how it fits in with the right care for the right patient at the right time, right? Well, moving on, and we actually are a little ahead of schedule, which is great. Dr. Scott Flynn is with us, and he's one of the co-chairs also for one of the RightCare settings, and he's a regional medical director with Blue Shield of California, and retired from the Navy. I see, Scott, that if you're at the beach, I think we're going to go back from virtual meetings to wherever you are, because that looks a little better than where I am. But you're going to give us the healthcare industry perspective. Yes.
Health plan perspective, yes.
Okay.
Can you hear me well?
Yes.
All righty. Yeah, that's actually a picture of Bonaire. It could be San Diego, but it's actually Bonaire, which is one of the ABC islands off the coast of Venezuela, Aruba, Bonaire, Curacao. And it's a place I go to about every other year to teach a diving medicine course. So wonderful place, world-class diving, if you ever get a chance to go there.
Did you say there's a medical course there?
Yeah, diving medicine.
Okay, I'll put it on my list. Thank you.
Yes, yeah, it's wonderful. All righty. Afternoon, everyone. Just want to give a quick update on what's been happening from the health plan perspective with COVID and some of the advances we've been doing. Next slide. All righty. perhaps we don't have my slides, and I'll just go ahead and talk about it. One of the things that we did, we had almost immediately was we were asked to participate with the California Department of Public Health to expand testing. And, you all remember when we started how hard it was to get tests and following the CDC guidelines and how strict those were. And we probably missed a lot of positives early on because we didn't test them because we didn't have enough tests. It was all about prioritization. And now that's getting much better. It's interesting for the testing. It was talked about a little bit earlier when you have the return to work criteria, getting 2 tests 24 hours apart that are negative. That's proved to be very problematic, as we heard some folks have been shedding virus for weeks. We don't think that people are shedding virus at least the past 9 days after initial infection presentation. So we tend to encourage folks to use the 10-day and then 72 hours symptom-free is when they can go back, because they may just be shedding viral remnants, skeletons, whatever you want to call it, coming out. So, but it's nice to have those tests available now. Full disclosure, I also moonlight in urgent care, and just worked yesterday, and we're actually being encouraged to do more testing now versus following strict guidelines to try to get more of an idea what's going on up there. So definite paradigm shift for us. We had telehealth already as a benefit, and we were paying providers on par originally. It was following CMS guidelines on what it was. And so all we did whenever the COVID started was making sure that we eliminate all restrictions, and also we're paying at par for what telehealth was. So that was a fairly easy switch for us because we were already down that path. The real question, of course, is going to be, as some folks alluded to earlier, what's going to happen after COVID? What is going to be the new normal? We also did our own outreach to our high-risk members and tried to make sure they were having their needs taken care of. And a lot of the high-risk members had already been approached by their provider groups too, our provider partners, but I'd rather have them contacted twice than uncontacted at all, and something fell through the cracks there. So we did that, and that was a big effort for us also. Waived member contributions for testing and treatment. Most health plans did that also, so I think that was a very good thing to try to eliminate barriers for concerns for people having to go for care. We help providers with over 200 million in programs and decrease administrative burden. For example, we eliminated prior auths for if you're going to transfer from a hospital to a SNF or other facility. So that was something that we took proactively to try to make it easier for everyone. And we gave to the community with grants and partnerships, focusing on the underserved through our foundation. As you're aware, the disease seems to be affecting lower socioeconomic status more severely than it does upper. And so that's why our foundation has been more focused on the underserved and trying to help support that. For members, one of the real questions is, what's going to happen when we have all this pent-up demand and people are not getting care? We hear about the hospitals and the ERs not seeing the heart attacks and strokes like they have been. Some of them probably happening, and people are just waiting it out at home. They're probably more afraid to come into the ER hospital than they were in the past and worry about dying from COVID, and instead they're not taking care of themselves. I just saw a patient on Wednesday, 54-year-old man who had chest pain when he woke. I woke him from sleep early in the morning. He went to work anyhow. Then he went home to go sleep it off, quote unquote, and he couldn't get to sleep. So he finally came in. He came into our urgent care and had an MI going on, but literally had it for 8 hours before he showed up. And he was really hesitant about coming in, he said, because of the COVID. So it'll be very interesting to see what happens with these folks delaying care, chronic condition care, hypertension, diabetes. We'll see how this all plays out. Another interesting thing is the employment status. It was interesting. You saw the snafu with the jobs number. And it didn't make common sense that suddenly the jobless claims suddenly dropped, and they didn't. So it was good to see them figure out where their data had messed up. But insurers like us and members, and I'm sure provider groups wondered, a lot of small businesses going out of business or people furloughed, laid off, will they come back? And without that insurance, there's going to be a large number of folks that don't have that care. Now, the question will be, will they be able to convert over to COBRA, which is, most of you know, is very expensive, or go into Medicaid, Medi-Cal, or exchange plans either. So that change in insurability and insurance could really affect access to care, and also for providers, a loss of revenue and a definite change in payer mix from a lot of folks who are insured by their small business over to the Medicaid and or exchange side. A lot was talked about already about using virtual solutions to help improve access to care. I thought that was an excellent presentation that we just had, and about, does it really improve access? Does it cover pent-up demand, or does it create its own demand? How is it doing for quality? There's a lot of questions still to happen. So it's going to be interesting to see how this all plays out in the future. And uncertainty continues to go. Great presentation by Bill about COVID and the current research. And it also reminds us that there's a lot of stuff we don't know and not sure how it's all going to play out. So it'll be interesting to see for everyone. So that's all my update I wanted to give, and I'll stand by for questions. Thank you.
Thanks, Scott. You know, what I'd like to do is fill in some of the questions in this period for the speakers who have been online with us all the time, that there have been some questions, some of which have been answered and some of which are still open, but I think the whole community that's listening to the presentation might be helped by this. So if I could have the speakers and whoever would like to answer the question. There was one for Dr. Marson from a large community health system. They're doing 80% telephone video visits now. And the question was twofold. One is that how do we deal with the fact that only 40% of the patients have the tech expertise or knowledge to be able to participate in such? And then the other issue of the payment, that is CMS and California DHS going to stop payments for this as soon as the emergency crisis with COVID is over? Do you have some answers or ideas?
Yeah, so thanks. I accidentally clicked that I would answer it live and then type something back to Scott in the chat. Oh, I'm sorry, it's Jim Schultz. I put Scott. Sorry about that. Oh, man.
That's okay.
Anyways, yeah, so I do think that is absolutely an issue, right? We're doing studies on this right now with our patients, looking at video visit, technical difficulties, those that are converted to phone, things like that. We have ways of tracking that. We are tracking our help calls. And there is a fear that folks that are having, and then looking at the patients that do have video visits versus those that are not. And there's a fear that there is this socioeconomic divide, that those in rural areas, those without means, are more likely to have technical difficulties and things like that. Our goal is to eliminate the disparity that way, but there's a real fear that way. And I think that you probably say it right, that if there's 40% have issues with this. So a lot of people have phones, not all of them. A lot of times we have to do it over cellular, as opposed to, because the internet is less likely for that to be available. Our CEO is talking about getting these vans that the Sacramento Unified Health District is doing, which is mobile Wi-Fi and going around. He really wants to be able to address these issues, but it's nationally known, and there are efforts. So the FCC has for a long time put out funding for telecommunications technologies across the different states. California it's probably about 12 years ago, we developed the California Telehealth Network, which still exists through OCHIN, that gives supplemental funding for folks that need internet access to rural communities and things like that. And then the USDA actually offers quite a bit of money in terms of the hardware and technology. It's not for personnel that way. related to telehealth. So I think it's an issue. We continue to try and advocate to address this digital divide. And short of that, I wish I had a better answer. And then regarding the payment for the FQHC, so that's a great, I think that everyone is towing the party line that, hey, this is going to end. This is only during the emergency, but I'm just hoping that similar to this horrific police violence, the country's reaction to that, that we would have a reaction similar to that. And I think that we cannot, folks, this is a way to get to folks that may not have otherwise access to healthcare. And if they were to try to reimpose these restrictions, I expect that everyone would be calling their representatives to not let this happen. So it's easy for me to say, but I'm cautiously optimistic that it will be extended beyond June 30th. And I sent out links to the Center for Connected Health Policy here, which is the National Telehealth Policy Resource Center. If folks are not aware, the third Friday of every month, there's a California, it's mostly a California call where we review California and federal legislation related to telehealth. And we're watching this closely, and all of our partner organizations like the AAMC and the California Medical Association are advocating that these restrictions not be reimposed. I'm sorry for talking so long.
I'd like to ask another question. This is Hattie Hanley, Right Care Initiative. And I have to say, I had my first ever video visit with one of my favorite providers who I rarely see because he lives far from me. But back when I was a college student at UC Davis, and they were diagnosing me with pneumonia, my sister, who worked at Stanford Medical School, had me come down there to have a consult there. And that's when I was diagnosed with asthma. So I think that one of the things that telemedicine is doing is it's allowing us to access different specialists more easily for things that don't need an office visit. And frankly, the amount of effort it took me to be able to have that really important expert consult, it was a night and day, of course, from when I was a college student struggling mightily to breathe at UC Davis, partially because of the burning of the rice fields there, which we've stopped doing. But just a few days ago, I had a consult with that same provider who originally diagnosed my asthma. And it took no time at all. It took half an hour at the end of my workday, and he was able to change up my medicines once again. And I think it's going to change. I think it's going to improve patient care, and then we have to ensure that it remains available.
Thank you.
Hattie, you're ahead of your time always. You are at the forefront.
I will try to ignore the insult to UC Davis and the plug for Stanford, but no, you're absolutely right. I've had in the pediatric ICU where I work, there's been extraordinarily rare metabolic conditions, a child in our ICU, and we connected, the center, it was in Cincinnati, right, where they have the biggest case series of these patients, and we invited their specialists to help guide us. We were doing all of the right things and things like that, but the opportunity to be able to involve otherwise very difficult to get specialists for like rare things is a great opportunity. Again, however, you have to make sure, that somebody isn't just, hey, oh, here's a pneumonia, here's a Z-Pack or something like that. I mean, we have to be careful with it too. There's lots of opportunities, but we need some guardrails.
I agree. I think
speaking of that, do you think that having some type of, I'll choose the word, guidelines for, utilizing telehealth, might that be in the offing in the future to getting it, where it should be?
So Dr. Peden, you can answer that? And
well, absolutely. I think as James and others said, I think we have a lot to learn. Where is this most effective? What are the barriers? which patients doesn't it work for. But I think already, and I'm sure that others have had the same experience. I remember at our virtual care committee, 6 months ago, having the discussion where we always had to see the first visit had to be in person. And of course, again, if you've actually done this, the first visit, you can talk about what's wrong, you can order the tests, and then you can meet perhaps down the line when you have these results, rather than bringing the patient in, sending them away for some other thing. So I think there's still an awful lot to learn. I was just going to say with, the rare diseases, we've been working on a project we're calling Keck NeuroConnect, which is using the eHealth platform. And if you look at the data on patients with complex epilepsy, in the US on average, it takes apparently 9 to 12 years to get to a super specialist center. And we've been bringing that time down by working with our partners in the community and sharing the learning. So there's also ways, particularly academic medical centers can share and work much closer with the community through these kind of platforms, but also accelerate patients getting to the right place.
And one other comment just on the guardrails. I do think, again, there's lots of opportunities, but I'll give you a personal experience with the health plans where I was seeing a patient with a complex cyanotic congenital heart disease that I knew very well and was able to help them and saw the patient. I think that really went well. And we submitted our bill and it was denied payment because this health plan has an exclusive contract with one of these third-party folks who, by the way, if they tried to see this kid with cyanotic complex congenital heart disease, I guarantee would not have known what they were doing with that. But, again, working with organizations in this California Connected Health Policy, now there's a law now. You have to be able to include your primary care providers with this. So opening up of it is good. And that sounds great. But I think we're going to go through this and learn where it's not working and hopefully continue to steer it in the right direction.
I want to apologize if I offended UC Davis. I love UC Davis. They are, some of the most excellent providers in the country. But at the time when I was an undergraduate at UC Davis, the care that was being provided at the Student Health Center was what I was calling into, that I had a very bad experience with. But frankly, you would no longer have to put up with that, because I think it might drive out some of the really poor providers because patients will just easily opt to see somebody who's known to be quite excellent. I have a different question for you, Dr. Marson, if I may, and that is, do you also work in machine learning? Because one of the things that our group has been talking about for quite a long time is what's in the medical record that we're not yielding to then find who's at high risk, for instance, those with positive coronary calcium scores or the less complicated things like just hypertension and hyperlipidemia, et cetera, to find patients who need proactive outreach. Could you just talk about the interaction between that and telemedicine?
Yeah, so I think that's another kind of something that telehealth people are talking about, but health informaticists, big data people are also talking about, and those Venn diagrams are certainly overlapping. And you're absolutely right. There is a world's opportunity to look at data that we do have, or imagine if you have it everybody's glucometer, Fitbit scales, phone data activity. Sounds Orwellian or whatever, but we would be able to predict high-risk patients. And yeah, we have a center working on that, and that's a huge opportunity. I think it's very tough. I don't want to oversimplify things, but hospitals, doctors, clinics are paid to see per patient, and they're paid to see sick patients, and they're paid to fix their problems, right? So an investment in our ability to keep patients healthy or lower the risk of a stroke 5 years from now, I hate to say follow the money, but we're less incentivized financially to do that than we are to do, I don't want to say like us, like UC Davis is doing that or whatever, but it's just the way the money flows right now. I think that there's great thoughts out there, but we have to be able to be paid to make these investments to keep patients healthy. And hospitals aren't necessarily like to do that. And again, community health centers, a vital part of delivery, healthcare delivery in the United States for the marginalized populations, you know, they're paid per encounter, right? And to be able to invest outside of that to keep patients healthy, it's just kind of, it's not necessarily in their books, unfortunately.
Jim and Carol, I have a question for you based on your disruptive approach for telehealth. And that is for both of you, do you ever see a possibility that we could be obtaining this information from the stuff that I don't spend a lot of time, that is glucose levels, blood pressure levels, et cetera. Much of the adjustment for diabetes, for hypertension, et cetera, is relatively simple and could be done with that data coming in with what I would call artificial intelligence, so that we could, in fact, think out of the box, replace physician visits, healthcare visits with artificial intelligence. You would get a call or contact from Dr. Watson, who would tell you what to do. You would communicate with Dr. Watson related to that, and that advice would follow through at that point, which could significantly, I think, reduce healthcare costs because we would take someone out of the loop. And obviously, we would recommend this for the relatively simple or easier to manage entities, which are somewhat tedious to add up all of the time. And we'd save the more complex cases for referring to physicians or healthcare providers trained in that area.
Yeah, yeah, I think that's the way things will go. I mean, already, as I referred to a talk last week or 2 weeks ago about home monitoring and treatment of blood pressure with, you know, pharmacists. I think there's a lot of things we can already be doing utilizing this technology. I think, as you say, there's a lot of work going on to have patients monitored at home. One of the problems at the moment is, you know, how do you manage all the data that's coming in? And therefore, I think you do need very sophisticated systems, AI, to sieve that data and only alert about true alerts. Otherwise, it becomes overwhelming. So yes, I think it's the way forward. I think we can start now with simple things and wait for the more sophisticated systems to get there as well.
I completely agree with Dr. Pini. I mean, there's an example. So with just diabetes, right? Right now, the patient comes in, dumps their glucometer, or they, you know, artificial pancreas or their insulin pump, and that's the way we get their information. That data, we should know every dose of insulin that's being administered, every glucose level, all of that stuff, and we could be more passively monitoring that and identify problems early. But then it's huge data. What comes to the provider, what sets off an alert, and then all of a sudden what becomes actionable, right? So if somebody gets really, really sick and you had this data and they say, well, doctor, this is terrible, but there's legitimate concerns that I hear that, well, you had access to their low glucose. You should have seen that they weren't checking their glucose and that it was out of whack, and you could have prevented this badness from happening. But there's also kind of like, once you have that data, you know, who's going to be held accountable for that?
Mm-hmm. I mean, there's so much we can do. Again, if we're thinking about the elderly, there's been work for at least 10 years, if not more, on sensors showing if they're moving around or not. But again, who's watching it, who's taking responsibility, who's alerting? Those are all things we have to work out, as well as just the artificial intelligence.
On a psychological basis, would a patient be able to, in fact, relate to an artificial intelligence, Dr. Watson giving them advice? Or would they be prone, do you think, Jim, to ignore that advice, saying it's a slightly remote voice and I'm going to ignore it?
Well, so I think, again, it has to be steady, but there are things that, let's say, if you're not checking your glucose, a text message will come up like, hey, you haven't checked your glucose all day, or something like that. So, and I think to a certain degree, those reminders can be helpful and should be helpful, like perhaps the elderly, right? I had that one slide of the pills, right? They can tell when you open your pill box and things like that. Now they have these little pills that you could microchip on it. You have a Band-Aid on your flank and it dissolves the microchip so they know exactly when you took that pill, right? So again, getting a little bit Orwellian, but the technology is there. And yes, you know, I don't know about you, but when I go on to a website and try and interact with a bot, it's pretty annoying to me and unsatisfying where I want to be able to talk to the person. However, again, I give the example of text message reminders, things like that when they don't see input on the patient, let's say to check their blood pressure every day. Those can be helpful, but it's a lot of work has to be done on research.
I mentioned a colleague of mine, Dr. Leslie Saxton. She has the virtual care clinic at USC. She works with the US military, and they found with the military that people with post-traumatic stress disorder will respond to avatars better than to doctors because they feel there's safety. And they're doing very, very sophisticated work with the avatars, recognizing facial expressions and things. So I think way down the line, this technology will be available. There is already a lot of work going on with it.
Dr. Balmer, I will tell you, my mother would listen to the robot more than she would take my advice as a physician. But I have a question. Speaking of AI, Dr. Balmer, you mentioned that there are 2,000 trials ongoing now for what we should be doing with COVID. Do we need AI to sort of sort those out quickly as to what we should really be doing?
Well, we certainly need AI for hydroxychloroquine because as you remember, there was a publication of about 5,000 patients who had been on it. And the data was prepared by another company and it was pre-published that there was no benefit from that. And then when the authors tried to get the full information, suddenly, quote, for HIPAA reasons, it wasn't available. And the co-authors felt they did not have confidence in that information because they couldn't personally review it. And those articles were withdrawn from the medical literature. So the difficulty in getting this data, big data, together and assembling it and reviewing it to make sure it is accurate is complex. And I can tell you, we oversee a lot of big data for the state of California for PCIs and other things. It takes a while to get through that data and to verify it. And so that is certainly a concern for it. So I think that we definitely have to come up with a better way of adapting to big data to come up with systems that can analyze it in a reliable and validated way before that information is released at that point in time. So absolutely, we need it. We need better systems for it. But there is far more information available in big data than we're currently using. So it's an underused area that we need to work further on. But it will take time to work through the problems with that. Now, I know we had a panel here at the end, which we may not get to, but are any of the panelists on board that would like to ask any questions of our presenters today?
You know, I've been checking the list of who is online with us, and I'm not finding that they are still with us. So these are practicing doctors who are doing multiple things. And so I think this discussion is really quite good. And it's exactly what we had in mind, to have some of our co-chairs from around the state discussing the big issues. And I have a question myself for Dr. Marson and others who want to chime in. And that is, what are the best practices for outfitting patients who need home care, who need telehealth, who are elderly? So I know the VA gave a great presentation about how they are having really good success with their approach. And we've had several of the doctors in this group with elderly parents have a very challenging situation getting their elderly parents to adapt to the technology. So could you possibly address what are the best practices there, Dr. Marsan?
So I'm a pediatrician. So one of my colleagues, I'll give them the first. Dr. Peden, you're.
Dr. Peden, you're muted.
Okay. Yeah, so it's about the elderly again, Hattie. Sorry, I was replying to the chat.
Yes, so we have a situation where a lot of older patients who are in their homes are intimidated by technology or don't have technology, such as our own dear Dr. Zaher has expressed to us, and also Dr. Jambroni, where they have provided their families with the technology, but that technology isn't particularly working for them. We did have
we're just writing a review on this at the moment about delirium management and technology. And, I think that we need to reflect on ourselves. How have we let a group of patients that would benefit most from some of these things that we have be left unable to use it? And I here I'm talking about probably the over 85s. So certainly, I think most people between 75 and 85 are very au fait with this technology. But I do think that people who are most at risk at the moment from social isolation and failing to take their pills, and the ones that are really being locked down because of their healthcare risk with this pandemic, they're very vulnerable. And I think going forward, and we have to involve the tech companies. How do they make devices? And there's some available already that are very, literally have big buttons that say press here. Just to be, if you don't see very well, if you can't feel very well, how do you use them? So I think, we need to bring Silicon Valley on, the best and brightest minds in this area, and get them to think about this fast.
Well, we've certainly been trying to engage them. They're not that easy to engage. If any of you have the contacts to do that, we would love it. We had a presentation by Dr. Cece Wu to our Silicon Valley group about how she uses this one just example of a technology that works for her family called the Grand Pad, which is just essentially an iPad that's been outfitted slightly differently is the understanding that I have, but I haven't seen a best practices kind of presentation on all that's available and how. So we've had several different presentations about things that can come right out of the box and be readily usable. But I think maybe what we need to have are some videos that we could teach people how to use the devices by sending them a visual video that would just pop open or something like that.
Hattie, that's certainly an enormous problem, especially as we approach the elderly who may be less tech savvy than the 5-year-olds running around today. And we've had it in family members that we've had where you can present, and this was a VA, a very good scale that measures and documents and communicates with the healthcare facility, blood pressure readings, et cetera. But there is still a fair amount of effort that needs to be done in order by the patient to, in fact, interact with the system. So I think as we go on, we'll continue to find ways of making it even more convenient and seamless, so that what you would like is what's there in the house is equivalent to a caretaker. So when the patient gets up in the morning, there's communication. You need to do this, let's sit here, put this on, et cetera, because they forget from day to day what they're supposed to do. And often that's a real problem with the data we get if they're not providing it for us. So I think we've made a lot of improvements in it. It is doable and workable at this time, but we could certainly work on making it even more seamless and convenient, especially for older or disabled individuals.
I forget day to day what I'm supposed to do. So
Thank you for saying something we all wanted to say. But
yeah.
So you do not ask Alexa or, hey, Google, what your calendar is for the day.
If I remember.
All right, on that note and disclaimer, I think we've used our allotted time. I think this was a very instructive and helpful meeting today. I thank all the participants and all the presenters particularly. And the next meeting is June 23rd, which is just 2 weeks. See, I don't even know what day it is, so.
And it's an evening event. It's 4 to 6 p.m. So that works for some calendars better than this noontime framework that our Los Angeles and Capital Region prefer. Our Bay Area group prefers the 4 to 6 p.m. And so we're going to have some very special presenters from 4 to 6 p.m. On Tuesday, June 23rd. One will be a bench scientist from the National Heart, Lung, and Blood Institute, Dr. Ramali, who was recruited by Dr. Evelyn Stock, and we'll be learning truly cutting edge information about inflammation and therapies evolving. I'd like to invite all of you to join us for that. We'll also be hearing from UCSF, Dr. Stock and Dr. John Kane, molecular cardiologists, to help us through this crisis. And I just want to thank all of you for your magnificent work and your, being at the front lines, trying to make things better for patients. Thank you, Dr. Balmer, Dr. Marson, Dr. Carol Peden, Dr. Carol Zaher, and to our wonderful staff, Brian Vong, who will be leaving for UCLA, a joint medical school and public health program, but he'll be with us on June 23rd. That will be his last meeting. Also want to thank Megan Olson, Kathy Yarashevich, Jenny Wu, and our LA operations team, Alyssa Meyer and Bob Trine. So a big operation behind the scenes, and really, really appreciate everybody's pulling together for the greater good. And I just wish you all safety and wellness until we see each other again. Bye.
Thank you, everyone. And we